Good morning, everybody. When I was in England, they said, "Ladies and gentlemen, pray silence." My name is Leonard Lauder. It's my pleasure to be the chairman of ADDF, Alzheimer's Drug Discovery Foundation, and it is my greater pleasure to welcome you all here for this wonderful and very interesting symposium. We have a very interesting program for you today, but we're going to start off this symposium, for those of you who have been here before, is the most interesting that you can ever have, because this is where you get the real facts. Even though I live in New York, don't believe the New York Times. And this is where you get the straight story. So to be our MC today, I'd like to introduce a very well-known person, Andrea Mitchell, who is, as you may know, the host of the Andrea Mitchell Show on MSNBC and the NBC's foreign correspondent. She travels the world, and I'm begging her to bequeath her air miles to ADDF. And it's my pleasure, by the way, she and I served on the board of the University of Pennsylvania. She is great. She is wonderful, a dear friend, and Andrea Mitchell, please. Thank you.
Thank you, Leonard. Thank you, Leonard. Leonard has been my mentor and friend for many years. He sat next to me on the Penn board and taught me how to be a committee chair and how to be a good citizen of the university, and I follow his example, I hope, in small measure. But what Leonard has done in so many arenas, but largely here today, we know what he has done in creating this foundation, which does unique work. I mean, it is simply an amazing research organization, I'd say unique in its field, and unique among these kinds of efforts to try to find the research, the drugs that will prevent and cure this disease. As we all know, Alzheimer's is a staggering and rapidly growing problem. Just to review some of the data, about 5.2 million people, or at least known around this country, to have Alzheimer's. 1 in 3 over the age of 80 will develop it. Alzheimer's is the 6th leading cause of death in the United States. In 2013 alone, it cost the economy an estimated $200 billion, and I suspect that is way underestimated. I don't know much about economics, but I live with one, so you get something by osmosis. We know that there are no drugs available yet that can prevent or even slow the course of this disease. And with all of this in mind, the great optimism that we have here today is because of the resources that ADDF has created and the work that Dr. Howard Phillott has done. A unique aspect of ADDF is the precise single-mindedness of its research, of its mission. The funds, the scientific research, all go to discovering drugs that will one day prevent and slow the course of this disease. To treat and cure Alzheimer's disease is our sole purpose. Focuses solely on funding and on finding the most exciting new research opportunities, cutting-edge research for a cure anywhere in the world, and that is another wonderful aspect of ADDF. We invite you to join us today. Thank you for your presence, all of you, to learn more, to support the research, to help this extraordinary scientific challenge. The founding executive director of ADDF and our chief science officer, Dr. Howard Phillott, is going to share his research, his answers. He is not only a researcher, but he has a clinical practice, a geriatric practice, and so his research is so fact-based and so experientially based that this goes beyond the laboratory to the real-life experiences of patients such as those we all know in our own families and among our friends. We're going to leave time for you to question Dr. Phillott as well. He has a presentation today, so I don't want to go any longer at all, but he is the driving force behind all that ADF has done over the decades. He's had a distinguished academic career, as many of you know, at Rockefeller University, is currently the clinical professor of geriatric medicine, palliative care, and neuroscience at the Icahn School of Medicine at Mount Sinai. You can read much more about Howard in your program today that you'll be receiving at lunch. What you won't read also, though, is that he is so smart and so compassionate and such a caring physician. And that is just among the reasons why we're so fortunate to have him here today. So Dr. Phillott, if you could join me, I know you have your own presentation. And let me just say that some things are beyond our control, my control. My program, which has aired for 7 years at 1 o'clock, which meant that I could not stay for fun and lunch and fashion, but have a better conversation with all of you, it's been moved this past month to noon. So I am right up against the deadline to be anchoring the news up on Nebraska Avenue, which some of you may know at our studios. That said, so much that we generalists in journalism deal with. There's a new study on mammography today that I'm going to have to deal with. There was the study, the Canadian study, which raised a lot of questions in people's mind, and my own doctors at Memorial Sloan Kettering have said that it was really badly reported by the New York Times and by some of the networks. So we know with diseases such as Alzheimer's and breast cancer and other very widely reported diseases that the general media don't understand these things. And one of the recent reports about Alzheimer's was this report that there is a blood test, a simple blood test with 10 lipids that can predict the onset 3 years in advance of Alzheimer's. So if you could address that as you begin.
Thank you for that kind introduction, Andrea. Thank you very much. So actually, I want to thank everybody for coming today, and thank you all for listening. The Holy Grail, just to get to the question at hand, the Holy Grail of our diagnostics in Alzheimer's disease would be to develop a blood test. And we all want one. And there have been any number of blood tests that have been proposed for Alzheimer's disease. One of the problems with blood tests is that Alzheimer's is really a disease of the brain, and it's been very difficult to develop blood tests for diseases of the brain because a lot of what happens in the brain doesn't actually get out into the blood. So we've seen a lot of blood tests. This is one of them. It is a panel of 10 lipids, which is kind of interesting because these lipids are what forms the membranes of cells in the brain. And so what the proposal is, the theory here behind the test, is that as the brain cells fall apart, these lipids get out and they leak out into the blood, and we can measure them. And this would be a great thing. It was done in a relatively small group of patients. One of the strengths of the study is that these patients were followed over time. So we saw the change in the blood test over time, which is a strength. But one of the weaknesses is that the same lipids that are in these brain cells are also in every cell in our body. And so the study was done in people with Alzheimer's disease, but it had controls who didn't have Alzheimer's disease, but it also didn't have people that had congestive heart failure or kidney disease. So we need more work. And I think one of the things that this test illustrates is just what I'm going to talk about, which Andrea mentioned, which is it's not only the media, but it's all of us who need to understand evidence and what the strength of evidence is. And that really is a great segue into my talk, because I'm going to talk about how we can learn from evidence and how you all can evaluate evidence when you hear about it, for example, in the daily news. So with that, I'd like to just move forward and start my talk. And since I thought that one of my themes today, or my main theme today, would be actually about women, since this is the great ladies' lunch. And so let's just have some facts. More women get Alzheimer's disease than men. And this is a fact. And there are any number of reasons. Women live longer in general. But also there's a biological phenomenon that I'm going to return to later in the talk that may explain why women are, despite the fact that they live longer, more at risk. Most caregivers of Alzheimer patients are women, spouses, daughters. Many women caregivers end up in poverty. They spend down the couple's assets, and then the husband goes in a nursing home or dies, and the woman is left impoverished. And finally, most people, about 90% of people in nursing homes are women, because again, they've spent down and they end up often on Medicaid in nursing homes, which is great for men in the nursing homes, but not so great for women. Now, the other thing is that men and women look differently. Our bodies are obviously different. But I think most of us who are married or have relationships or know members of the opposite sex know that it seems like men and women think differently. You have a different emotional state, and we think differently. And this has been known, as I'll mention it, for many, many decades in terms of biology. But what we're seeing here is a couple of things. One is the amazing advances that we've had in imaging, in brain imaging, that is being used in so many different ways to help us understand normal people and disease. And what this study just came out is really fascinating because it used MRI to actually look at the circuitry of the brain in people. And what you see here is that men tend to be very lateralized, and they tend to have sort of front to back circuits, and you can see it here. And maybe not so much stuff in the frontal lobes where we have reasoning and judgment and things like that. But we're really built to take visual material that we see in the jungle, we see the lion, and we can react to the lion really well. And we're very sort of task-oriented. Whereas you can see that the woman, there's much more both sides. We always suspected women use both sides of the brain better. And here's the evidence, in fact, that looks like it's true, that both sides of the brain are better connected in women. And again, the frontal lobes are more highly integrated into the rest of the brain. Now, I'll just ask you to think about it. Why does this happen? What's the biological, scientific, neuroscientific reason for that? It's fascinating, and it has everything to do with estrogen. So what I want to do today is actually bring back to you always everything that we talk about. How does that help us develop drugs for Alzheimer's disease? Now, it turns out also that women played a critical role in the discovery of Alzheimer's disease. This is a very famous painting, and this lady is wearing a sort of semi-purple pink dress. This was one of the first dresses in the late 19th century that was dyed with synthetic chemical dyes. Because prior to that, all the dyes came from plants. So there was the advance of chemical dyes, the chemical industry, synthetic dyes. And this painter painted this because it was such a revolutionary thing that this woman of fashion was wearing a dress made with a synthetic dye. Now, it was this dye, called Congo red, that led to the discovery of Alzheimer's disease. Because what happened around 1900 was that we had two things. One, the modern microscope, and I won't go into that to save some time, and then scientists like Alzheimer, physician scientists like Alzheimer's, started, when people died, they looked at the autopsy and they applied the dyes to the tissue to see what would happen. Basically, it was an experiment. And when Alzheimer's did that in a 52-year-old woman, he took this dye from the dress, put it under the modern microscope, and here's what he saw. He saw a brain that was filled with stuff that shouldn't be there. And this is actually what the slide looked like. And you see these big, round accumulations of stuff, which we now call senile plaques or amyloid plaques, and these dying neurons, which he called tangles. And you see them all over the brain, dying neurons and plaques. And in this cartoon from the Alzheimer's Association, you can see that normal neurons have lots of connections, they look healthy, and there are no plaques, and then we have plaques. Now, it turns out Alzheimer described the disease. It was a combination of the clinical presentation of dementia in a 52-year-old woman with this pathology. That's Alzheimer's disease. It also is that these two findings are the lead reasons for which we are trying to discover drugs. So most of the clinical trials today, up to date, and we're talking about billions of dollars, have been spent on trying to remove or prevent the accumulation of these plaques, thinking that the plaques are the killer of the brain cells. And so far, all of that has failed. And one reason it might be failing is that these are not really the cause, but just as a byproduct of the disease. There's scars in the brain. We're still having research, phase 3, late-stage clinical trials on trying to remove the plaques. Eli Lilly is doing one. Merck is doing a clinical trial with a beta secretase inhibitor, which just means that they're trying to prevent the formation of the plaques. And what the field has moved towards more recently is that we're trying to prevent the brain cells from dying. And that's mostly what I'm going to talk about today, because when the brain cells die, regardless of whether it's from the amyloid plaques or low oxygen or lack of energy or head trauma or whatever, when the brain cells die, we lose our minds. And so trying to figure out why the brain cells are dying and our foundation has really focused on this much more. We're not funding amyloid anymore for many years now because we wanted to move over to why are the brain cells dying. Now, I thought today I also talk a little bit more about prevention because I always get asked about prevention, but I'm going to put a little twist on it. And what I'm going to try to tell you is, again, I want to get back to my theme, which is how do we develop drugs for Alzheimer's disease? And my theme today is going to be not only to tell you about these exciting advances in prevention, but how we use that knowledge to develop new drugs for Alzheimer's disease. Now, this is interesting. You probably thought about heart disease beginning in teenage years, high cholesterol, and you develop plaques, it takes 50 years, and finally you get a heart attack. But this is a new concept, that cognitive aging and dementia begins in midlife, it begins in teenage years, and it even begins at birth in people who have genetic problems like ApoE4, which I'm not going to have time to talk about today, but is not a cause of Alzheimer's disease, but a huge risk factor that we're trying to develop drugs to fix. And so you can see, you probably can't read this, but throughout the lifespan, there are multiple factors that ultimately cause Alzheimer's disease. Alzheimer's disease is a disease of aging and a disease of old age. It's the accumulation, and I'm proposing this to you, it's not a mutation that causes one thing. It's the accumulation of living on Earth over 80 years and multiple insults to the brain that leads to Alzheimer's disease. And that's why we think of it now as a disease of an entire lifespan. Now, I'm definitely not going to have time to go into all of the risk factors that we have, but there's an amazing number of risk factors that in the context of our entire lives leads us to ultimately lose our minds. And 1 in 3 of us will have Alzheimer's disease. I mentioned ApoE. I'm going to talk a little bit about sex in terms of gender differences, right? So sex is the biological term that describes estrogen versus testosterone. Gender would be the clinical. We're going to talk a little bit about the biology of the differences and how they relate to Alzheimer's. Let me just point out that medical factors are critically important. When you consider that 45% of people at age 70 have hypertension, 28% or 30% have diabetes, almost everyone has some degree of heart disease and high cholesterol, and all of these are important factors in damaging the brain. We think of them in terms of heart attacks and kidney problems and so on, but the brain is also an end organ in this and really gets affected. And we know now that these medical factors are so important to manage over the course of your lifetime, not only to prevent a heart attack, but to prevent dementia from Alzheimer's disease. Aging itself is known to be associated with inflammation, oxidation, something called epigenetics, and menopause. And we'll talk about menopause. And then you have physical exercise. You have lifestyle risk factors, physical exercise being the most important one, but psychological factors, which are quite unique in the formation, in cognitive decline. And if you just see these, and I'm sorry for those on this side that I'm not using the pointer there, but you can see here you have years of education. It's been shown all over the world that how you build your brain in young life with years of education determines your risk for Alzheimer's disease in late life. Again, think of it as a disease of the entire lifespan. If you build your cognitive reserve with education and ongoing continuing social and occupational engagement, you build your reserve against the damages and the ravages of being on Earth over the course of a lifetime. But it's also interesting that loneliness, neuroticism, distress, which is how we react to stress, depression, and conscientiousness as being a positive thing, sort of things that we control. All these psychological risk factors are also risk factors for Alzheimer's disease, probably mediated by the effects of stress, the negative effects of stress on the brain, because we know that stress kills brain cells. And again, there's a biology in that that can help us develop drugs for Alzheimer's disease. Dietary factors, again, obesity, Mediterranean diet protects against Alzheimer's. Obesity is a risk factor for it. Omega-3 fatty acids and DHA, I won't have time to talk about it. I've spoken about it before. Very important for the brain. Vitamin Bs have been shown to help prevent brain atrophy in aging. Vitamin D is a hormone that affects the brain, not just the bone. Substance abuse is clearly a risk factor. And head trauma, we're recognizing now that soccer and football and falling on your head in old age are all risk factors for Alzheimer's disease, and even environmental factors. So many factors that can affect the brain through so many different ways to kill brain cells. And if you think about strategy here, we can't control all these factors. But what we can try to do is as they enter into this funnel of damage, we can try to figure out ways to protect the brain cells regardless of the cause of the damage. And that would be called neuroprotection, which is one of the main strategies that I think is going to be very important in developing drugs for Alzheimer's disease. So we can practice all these good things, but still, maybe we can put off the onset of Alzheimer's disease by 5 or 10 years by practicing these prevention, but they're not going to cure Alzheimer's, and we're still going to need drugs. Now, one of the biggest advances in the last few years has been brain imaging to actually see the plaques. And our foundation played a critical role, I might say, at the University of Pennsylvania in developing this test, which was the first diagnostic test for Alzheimer's disease approved by the FDA. We started funding this at Penn in 2000 at a time when there was no money for it. I'm not going to go into it too much, but all I can tell you is that somebody who has mild cognitive impairment would be somebody who comes into my office complaining of memory loss at 65. Now, I can evaluate them, I can look at their risk factors, but if they really want to know at that point if they have Alzheimer's disease, in the past 20 years ago, 5 years ago, I would never be able to tell them for sure that they had Alzheimer's disease. And since 50% of people with memory problems at age 65, 70, 75 will go on to develop dementia in 5 years, but 50% won't, it would be really important for me and my patients to know whether they had plaques in their brain. And what you're seeing with this test is on a PET imaging exam that would be available in any city in the United States, that in patients who improved, they didn't have a positive test, they didn't show plaques in their brain, and in patients who progressed to dementia, that they do. They have the plaques, and we can see the plaques. But what's really cool about this is that it's enabling prevention, because just like cholesterol starts at age, in your teenage years, and you develop a heart attack when you're 50 or 60, the plaques, we now know from this test, start developing 20, 30 years before you have your first symptoms of memory problems or dementia. And that's enabling prevention because it's enabling us to find people who are, let's say, 45, 55, or even 65, who have plaques and are clinically normal and start doing prevention trials. And so that's a very different, very exciting part of what we're doing today in the field. Now, I want to go through levels of evidence. We started off when Andrea Mitchell said the media doesn't understand it. And one of the things I want to point out is let's take a couple of examples and look at levels of evidence and try to understand how we develop drugs for Alzheimer's disease and how we evaluate things. So let's just start with exercise. It's been really well established that exercise is good for your brain and it improves cognition and it actually prevents brain atrophy. And there's a whole neurobiology to this that actually started in animals. So we had little mice running on treadmills. We cut up their brains. We looked at their blood. We saw what was going on. And we learned a lot about the neurobiology of exercise. So we had scientific evidence in the preclinical sphere. Then we looked at epidemiology, which would be like just following people in the community over many years and seeing what happens to them. And that's how we learn about these risk factors. Most of the risk factor information I told you about was from epidemiology, observational studies, looking at how people react in the community over time. And we found out that people who exercise have a decreased risk of Alzheimer's disease. That's an association between two independent factors, but doesn't prove causality. So the type of evidence that epidemiology is rather soft but interesting because it generates hypotheses for us to study. Clinical trials are thought of as the highest pyramid of evidence because you randomize, and we funded a study like this, you randomize one group to exercise, 75-year-olds, another group to no exercise, you control for all the other variables, and then you look at their cognitive function over 6 months to a year or 18 months, and you see what happens. And sure enough, there have been a number of clinical trials in 75-year-old people, even in people with Alzheimer's disease, who exercise versus those who don't, in a randomized, double-blind, placebo-controlled clinical trial, and the people who exercise do better. They have better psychological function, cognitive function at 1 year, and their brains don't shrink as rapidly. So we have the highest level of evidence of exercise in terms of preventing Alzheimer's disease. But what's the implications for new drugs? And the question is, how does it work? How do we understand the biology in humans of this to be able to develop drugs? What is exercise doing to the brain? It's not just blood flow. It's two things. One is that there's actually a direct correlation between something called VO2 max, which is a biological measure of fitness. How efficiently does your body use oxygen? We can measure that. And that tells you how well you're fit. And there's a direct correlation between exercise, fitness as measured by VO2 max. If you ever saw Lance Armstrong on a bike with the thing in his mouth, he's measuring VO2 max. He has an amazing VO2 max. Between VO2 max, energy efficiency, using oxygen, and cognitive function, and brain atrophy. So that's really interesting, but what's the biology of that? And we're going to talk about that. And then the other thing is that we know that exercise produces those neurotrophic factors. Remember I talked about the funnel? It produces those neurotrophic factors. The brain is 3% of the body weight, but it's a huge energy utilized there. It uses 25% of the energy that we get from oxygen and glucose. That's where we get our energy. Now the mitochondria, which are actually ancient bacteria that entered cells of animals about 100 million years ago, and we have billions of these pseudo-bacteria in every cell in our body, including the neurons. And they're the power plants of our bodies, of our cells. They're the ones that take oxygen and glucose and make energy. And I won't go through the biochemistry of that, but that's how we get energy. Now, the brain is completely, because it's such a high energy utilizer, completely dependent on oxygen and glucose. If you go in a pool and you drown, the first thing that happens within about 3 minutes is you go unconscious. Your brain goes first. Diabetics, low glucose, below 60, they go unconscious just like that because the brain is so sensitive to its energy needs. Now, with aging, the efficiency of these mitochondria declines. And the same thing happens in diabetes because in diabetes, you get insulin resistance and the mitochondria can't use glucose. So why don't we learn from diabetes and aging and say, how can we improve the function of these mitochondria to improve energy efficiency in the brain cells so that they don't die from lack of energy? Now that theory has been around since 1980, but now we have drugs which we're repurposing from diabetes. We're funding one study, for example, at the Imperial College of London in the UK to use a drug called liraglutide, which improves glucose utilization in these mitochondria. And we're repurposing that drug from diabetes to Alzheimer patients to see that if by improving the energy efficiency of the mitochondria, we can prevent brain cells from dying and slow the course or even prevent Alzheimer's disease. Now, if the same thing happens with this, we asked the question in humans, what is the level of BDNF, which is the most powerful neurotrophic factor preventing brain cells from dying regardless of the cause? And we've learned a lot about it. And what we find is that people who exercise, their levels of BDNF go up. So exercise produces BDNF, it goes to the brain, and it protects brain cells from dying. So wouldn't it be great if we could develop drugs that mimic the effect of BDNF? And we spun a company out of Stanford University, and we're funding a number of other programs to try to develop small molecule pills, because you can't give BDNF to people, but we can develop small molecule pills that mimic the effects of BDNF, learning from exercise and other biology, to prevent Alzheimer's disease by, regardless of the cause of what's going on, we're going to have neurotrophic factors to prevent Alzheimer's disease. Now, the other thing is that we've known for many years that Alzheimer's disease is a disconnection syndrome. The brain is disconnecting. All the different centers of the brain, the language centers, the calculation centers, the abstract reasoning centers, they're all disconnecting because the brain cells, and actually this is actually an image from an MRI where you're looking at the white matter and you're actually looking at the connections between all these centers in the brain. It's amazing. And we know now that Alzheimer's is also a disease of the white matter, and these connections are falling apart. What are these connections? These are the axons. If you think about it, in the spinal column, an axon from a nerve in your spinal column goes all the way out to your fingers so you can go like this. That's a couple of feet long, right? Imagine if those get severed, then you can't use your finger. Well, it's the same thing in the brain. These tubules, they're called microtubules that carry energy and signaling from the cell body where input goes in here from other brain cells and goes out here at the synapse. These microtubules fall apart. They disintegrate. And when they disintegrate, you get loss of signaling, the synapses fall apart, the brain disconnects, and the cells ultimately die. So one of the theories, one of the approaches here is to protect these axons, they're called axons here, from disintegrating, for preventing the microtubules from disintegrating, from forming those tangles that Alzheimer's saw, remember we saw plaques and tangles? These are the tangles. These are the disintegrating axons. One of the things that's interesting is that the axons bring mitochondria down from the cell body to the synapse to provide energy at the synapse so that the two synapses can connect and function. So part of this energy deficit that we see in the brain is not only the result of the fact that we don't have enough mitochondria or that they're not efficient in using glucose and oxygen, but also that they're not getting on these tracks down from the cell body to the synapse. So by protecting the microtubules, we not only help energy efficiency, but those microtubules also bring the BDNF, and these are just two examples, down to the synapse to protect the synapse. Now, there are a number, I'm not going to go into this, but I just want you to know that there's also a number of other ways of protecting the synapse from falling apart. And I think for the sake of time, I'm not going to talk about them, but we have programs in every single one of these areas of developing new drugs to protect the synapse and these long trains that bring nutrients and energy and signaling down from the cell body where connections come in, they go out, they come in here, they go out here, and if this falls apart, the brain disconnects and you get Alzheimer's disease. And that's been well known for many years, that that's what happens because we see it on pathology. But we don't understand the biology. We haven't understood the biology. Now we can translate that knowledge into new drugs. Again, translating the knowledge into new drugs. Now let me close with one more story, and that's about women. We said there was some big news or reports recently that women are at greater risk for Alzheimer's. And it's true. And we know that. In fact, we've known that for over 35 years. And I just want you to see that this report says observations in a preliminary open trial of estradiol therapy, which is the naturally occurring estrogen hormone that is active in women, estradiol, for senile dementia and Alzheimer's type. Howard Phillott, lead author. The date of this report is 1985. The study was started at Rockefeller University in 1980. We've known about this for a long time. We've known that men and women's brains are different. We've known a whole lot about the neurobiology of estrogens for a long time. We know a whole lot about the chemistry of different estrogen molecules. So let me just go through the evidence again to let you see how we go about this. Okay, so again, the neurobiology. We've known a whole lot since the 1970s about the neurobiology of estrogen and testosterone on cells, on the brains of animals. We know that if you take out the ovaries of a mouse and look at their cognitive function, they don't function as well. So we mimic menopause in animals, and we can show that female mice that are taking their ovaries out lose cognitive function. So we can do it in animals. And if you replace their estrogen with estradiol, which is the naturally occurring hormone, the cognitive function of the mice gets better. Epidemiology is amazing in this field. Almost all studies show that not only are women at greater risk, but that at menopause we see that many women have cognitive dysfunction, and that women who take estrogens, primarily Premarin, which is not estradiol. So think chemistry now for a minute. When you've seen one drug, you've seen one drug. Women who historically have taken Premarin, which is a complex mixture of hundreds of estrogen-like compounds from the urine of pregnant horses, okay, that women who take Premarin in epidemiologic studies, the use of Premarin is associated with a decreased risk of Alzheimer's disease, like a 40–50% decreased risk. Interesting. But then there were few long-term clinical trials, and there was a clinical trial. My study showed that if you give estradiol, the naturally occurring estrogen hormone, to elderly women, their cognitive function improves. Then the NIH funded this huge study called the WIMS trial, Women's Health Initiative, $100 million, something like that. And they used Premarin. They didn't use estradiol. And they actually showed that women who took Premarin, beginning around age 65, right, actually did worse. They had more strokes and more dementia than women who didn't. And so how can this be that these are levels of evidence? Well, if you take the osteoporosis model, imagine if you started taking estrogen at age 65. women who take estrogen at age 65, the bone loss has already occurred because all the action is at the time of menopause. So we now think a critical window effect that at the time of menopause, when the ovaries fail, estrogen drops dramatically. And estrogen is a neurotrophic factor for the brain. Okay, in men and women, by the way, because testosterone is converted to estrogen in men's brains and is the active hormone in men's brains as well. So there are estrogen receptors in the brain, and estrogen use at the time of menopause improves cognitive function, particularly estradiol, which is the naturally occurring hormone. And so that now there's a need for studies to look at if women who go through menopause, who take estrogen, the same way we encourage women to take estrogens or other drugs at the time of menopause for osteoporosis, because there's a critical window effect in osteoporosis at the time of menopause with bone loss. But if you try to do it at 65, the horse is already out of the barn. It may be the same thing with cognitive function. Why are women more at risk? It may be because of the very dramatic and abrupt loss of estrogen at menopause, and then what we need to do is clinical trials of estrogen at the time of menopause and then follow women for many years to see what happens. That study hasn't been done. There was a recent study using estradiol, again, the naturally occurring hormone, in women to see its effects and reproduce what we found. But the real thing is that estrogens may not be safe. And so the drug discovery issue is to develop safe estrogens using chemistry, which get in the brain, don't affect the periphery, doesn't affect the breast, doesn't affect the uterus, so you're not at risk for cancer, get in the brain and bind to these hormone receptors in the brain to improve cognitive function and use the neurotrophic effects of estrogen to protect brain cells from dying. And that's the chemistry challenge that we have right now. So you see all these levels of evidence lead to this direction that we have to get at where we're going in terms of developing new drugs. So again, getting back to Andrea's comment, and my theme today is understanding evidence. Every day you read something in the paper, red wine is protective. What does it really mean? Are people talking about neurobiology? Are we talking about epidemiology? Is it the result of a clinical trial? Was it a valid clinical trial? Was it randomized? Is it really a drug study of a new drug? What is the level of evidence? And let me give you a couple of examples here. Here's some facts from epidemiological studies. And what I'm going to show you is that bread is bad for you. Here's the headline. More than 98% of convicted felons are bread users. More than 90% of violent crimes are committed within 24 hours of eating bread. Now, are you going to stop eating bread? I mean, what's the level of evidence? How can you interpret that evidence? What does the average person know about it? What's the biology of this? If you take bread and you push it on, a pound of bread on a cell, the cell's going to die. That's not a good science experiment. Here's another one. Living in South Miami Beach keeps you young. Okay? Studies of Miami Beach. These are observational, epidemiologic, long-term studies. In 1980, the dominant population of Miami South Beach was old Jewish women. In 2010, the dominant population was young Hispanics. What's the report in the news? Front page news. If you move to Miami Beach, you start out as an old Jewish woman, and you end up 30 years as a young Hispanic, okay? So we need to interpret and understand scientific evidence. And it's very difficult. It's very difficult for doctors because imagine, just go to the estrogen story. I have a 70-year-old woman come into my office, and she says, doctor, and I'm an expert. She says, doctor, should I take estrogens? And in clinical practice, we're always talking about incomplete evidence, we're always talking about risk and harm, and we're always talking about individual decision-making, individual values. How do you feel about what you want to do with your body? And I can give you advice, but ultimately the patient has to make the decision. So we need to be able to help doctors to understand evidence, and we need to be able to help patients and people understand evidence. And so our foundation, in our prevention initiatives, has just launched a new website. We have 2 PhDs on staff who are funded completely by an anonymous donor. And the website is Welcome to Cognitive Vitality. And what we're doing here is we're incorporating all the principles that I told you about today: neurobiology evidence, epidemiology evidence, clinical trial evidence, and even what the implications are for new drugs into this website. And I hope that you'll go there if you want. We have many reports on there already about vitamin D, about caffeine, and a whole bunch of other issues that people, including natural supplements, that many of us take. So let me conclude. I want to thank you for your attention. I want to say that I've been doing this 35 years. We can make an early diagnosis of Alzheimer's with great specificity today. I believe that there's many, many ways that we can develop disease-modifying drugs that I really didn't have a chance to talk about in these 25 minutes, but I'm very excited about it. And I do believe that by doing all the things that I mentioned to you in the early slides about prevention, that we can delay the onset of Alzheimer's disease and hopefully die a very peaceful death. But in the meantime, I just want to show you this. When I first entered a nursing home in 1980 and saw Alzheimer's disease for the first time at a teaching nursing home on Long Island, an academic nursing home, I was certainly shocked by seeing all these poor women, mostly in beds in this building. It was just a horrible thing. And I just never forget being told in my geriatric medicine training about positive attitudes towards elderly people and even people with Alzheimer's disease, which I've certainly incorporated into my life over the many years. This poem that one of the patients in the nursing home wrote, which was, "People see me as an old dragon, but once I was a young butterfly, and the butterfly still lives within me if you'll only look for it." I think we need to take care of people. We need to do all the things that we need to do to make sure they get quality care. But I think our biggest commitment to them is to find new drugs to prevent them from ever getting demented. Thank you very much.